Good afternoon to everybody joining this second webinar in our Experts on Air series on closed loop ventilation. My name is Caroline Brown from Hamilton Medical, and I'm joined today by Dr. Jean-Michel Arnal from France and Professor Marco Maggiorini from Switzerland. They're going to talk about how the closed loop mode IntelliVent ASV can help provide individualized lung protective ventilation for each of your patients. If you're joining us today for the first time, please note that your cameras and microphones are switched off, but you can ask as many questions as you like using the Q&A function. We hope to see many of you posting questions, and we'll try to answer as many of them as we can during the webinar. The session is being recorded, and you'll receive a link to the recording sometime next week. And now I'll hand over to Marco Maggiorini in the interviewer seat for today. Thank you, Marco.
Thank you very much, Caroline. It's a big pleasure to be here and chair this session for me. My name is Marco Maggiorini. I'm emeritus and former head of the medical ICU at the University Hospital in Zurich. I introduced in my ICU Hamilton ventilator 2014, and I was proud that within 1 year, IntelliVent ASV became the standard mode used in our ICU, where I would say more than 90% of the patients were happy with this mode. It's a big pleasure for me to introduce Jean-Michel Arnal. I would say he's not the father of IntelliVent, but is for sure the one person that has the most experience among us with IntelliVent ASV. He was involved in development of this mode. And Jean-Michel is an intensivist. He is working at the Hôpital Saint-Mousse in Toulon and leads there the interdisciplinary ICU. Jean-Michel, welcome among us.
Thank you, Marco. Ladies and gentlemen, good afternoon or good morning, or maybe good evening for some of you. So it's really my pleasure to be here. And this afternoon, we will talk about individualized lung protective ventilation. But before we start, we have a quick question for you. So just to warm up, how often do you individualize ventilation in your real practice? Never, sometimes, regularly, always.
So we see the results of this question that was addressed you by Jean-Michel Arnal. I see that, wow, it's impressive. 37% of the 35 participants, no, of the 71 participants are using IntelliVent always. And the majority are using it also occasionally. Only a few of you will have no experience with IntelliVent. That's a big pleasure.
Okay. Thank you. So just to inform you that I have some conflict of interest because I'm a part-time medical research manager at Hamilton Medical. So when we have to ventilate a patient with an injured lung, there is a risk of ventilation-induced lung injuries. And this will worsen the lung condition that is already injured. And the mechanism of this is due to the stress, meaning too high pressure in the aerated part of the lung, the strain, too large volume in a baby lung, in a small aerated part of the lung, and atelectasia. Atelectasia is result from repeating opening and closing of distal airways and alveoli. Another way to look at ventilation-induced lung injuries is to speak about ergotrauma. Ergotrauma refers to the energy transfer from the ventilator to the lung and combine all the ventilator setting, namely the tidal volume, the rate, the driving pressure, and the flow. And we can add on top of this hyperoxemia, because we know that hyperoxemia may cause or worsen lung injury, but also may worsen the other organs. So ventilator-induced lung injury occurs because we have a patient at risk and because we have ventilator settings at risk also. The risk factor regarding the patient is a decrease of the volume of aerated lung and an increase in lung heterogeneity. And this is why Wiley is more prone to occur in ARDS patients, for example. Patients with a strong inspiratory effort are also at risk. And also it depends on the chest wall compliance and on the vascular pressure, because Wiley is not only an alveoli problem, but it's also a perfusion problem. Regarding the ventilator settings, large tidal volume, as everybody knows, are associated with Wiley, but also high pressure, inappropriate PEEP, too low PEEP or too high PEEP, because low PEEP can create atelectroma, but high PEEP can create lung overdistension, and high FiO2. So there are many recommendations how could we prevent ventilator-induced lung injuries. Regarding the stress, we have to keep plateau pressure below 28 centimeters of water. But as you know, plateau pressure is a pressure to distend the lung and the chest wall. So it's probably more appropriate to assess the inspiratory transpulmonary pressure and to keep it below 15 at the end of inspiration. Regarding the strain, we have to adjust the tidal volume according to the compliance. The concept is that if we have a patient with a low compliance, to use a low tidal volume and the other way around. Why? Because we know that we have to keep driving pressure below 15, and driving pressure is tidal volume divided by the compliance. Then regarding atelectroma, we have to keep a positive transpulmonary pressure at the end of expiration, but this required to use an esophageal catheter. And regarding ergotrauma, we have only retrospective study on ergotrauma, but we have data showing that if we keep the mechanical power below 17 joules per minute, this is associated with better outcome. So this is how we have this sort of threshold. Regarding SpO2, there are some recommendations to keep SpO2 below 97. So actually, if we have to apply all of these recommendations for all of the patients intubated in the ICU, this is quite a lot of workload. It's possible, but it's quite a lot of workload because protective lung ventilation is a multi-parameter strategy, and it requires sometimes to use some special tools. So this is a second question for you. What tools do you use to individualize ventilation in your current practice? You measure plateau pressure and driving pressure, you measure esophageal pressure, you calculate mechanical power, or you use closed loop mode.
Let's see the results of these questions. Again, a large proportion of participants measure plateau pressure and driving pressure. It's quite interesting, but some of them, it's not just a few, it's 28%, it's measuring esophageal pressure, and more or less the same percentage is calculating mechanical power. So it's an interesting results of these to this question. Jean-Michel?
All right, thank you. So let's see how can closed loop ventilation modes helps. As you know, in conventional ventilation, we have to set ventilation parameters. These are the parameters to control PaCO2. So it's a mix of a tidal volume and a respiratory rate, the product being the minute ventilation. And on the other hand, the oxygenation parameters, which are a combination of FiO2 and PEEP in order to control PaO2. Adaptive support ventilation, ASV, is a closed-loop mode that adjusts automatically or select automatically the combination of tidal volume and respiratory rate for a given minute volume that is set by the user. an evolution of ISV is IntelliVent ISV, which is a full closed loop mode where all the main settings are determined automatically by the ventilator. Namely, the target minute ventilation is determined according to the end-tidal CO2 and the end-tidal CO2 set by the user, the target set by the user. Then there is the combination of tidal volume and rate is selected by the ISV controller. And there is an oxygenation controller that adjusts FiO2 and PEEP according to SpO2 in order to achieve a target SpO2 set by the user. So by design, ISV and IntelliVent ISV have some feature to ensure lung protective ventilation. Especially the VT is selected according to the respiratory mechanics, namely the expiratory time constant. So it means that if the patient have a low compliance, the ventilator will select a low tidal volume and the other way around. And by doing this, ISV and IntelliVent ISV limit plateau pressure and limit the transpulmonary pressure at the end of inspiration and maintain the driving pressure below 15. Also, in IntelliVent ISV, there is an automatic permissive hypercapnia concept, meaning that when the peak pressure reaches 25 centimeters of water, so it's not that much, already the ventilator will target an end-tidal CO2 a little bit higher, so it means decrease the minute ventilation. And by doing this, it will maintain the mechanical power below 17. Regarding atelectroma, to be honest, this is probably the weakest part of IntelliVent ISV, that PEEP is not set according to transpulmonary pressure, but it's set according to a PEEP FiO2 table. So it's set mainly according to oxygenation. So it means, in my point of view, that sometimes you have to turn off the PEEP controller and set it manually if you want to set it according to transpulmonary pressure. And regarding FiO2, SpO2, there is an oxygenation controller. So by setting a target SpO2, you can avoid hyperoxemia, I would say almost always. So we have some data to support the result of IntelliVent ISV. This is a prospective observational study that included 255 ICU patients. We did a measurement at the early phase of ventilation, meaning during the first 24 hours. And these patients were separated into normal lungs, COPD, and RDS patients according to standard definition. In terms of tidal volume, you can see that in normal lung patients, the patients were ventilated with a tidal volume on predicted body weight between 6 and 8 meters per kilogram of predicted body weight. A little bit higher in COPD, 7 to 10, and lower in RDS. In terms of driving pressure, what is interesting is that by using the ISV controller, the driving pressure is always below 15, whatever the lung condition. So the way the algorithm is working, it's adjusting tidal volume, but in any case, the driving pressure is safe. And in terms of mechanical power, in this study, we use the formula, the initial formula by Gattinoni, and also we found that the mechanical power was below 17 almost always. So this is the figure from the same results, showing on the left part the tidal volume. And for normal lung, the recommendation is to have a tidal volume between 6 and 10. And you see that almost all patients were on this, within this range, with very few outliers. Regarding RDS, the recommendation is to have a tidal volume between 4 and 8. And again, most of these patients were there. On the left part, on the right part, sorry, you see the driving pressure. And if we put a line at the threshold of 15 centimeters of water, you see that whatever the lung condition, most of the patients were ventilated below this threshold and with very few outliers. Now, if we focus on the group of RDS patients, so 129 patients, we splitted them in mild, moderate, and severe cases according to the Berlin definition. And again, in terms of tidal volume, you see that the tidal volume selected automatically by this mode is lower for the most severe RDS. The driving pressure is always in the safe range, and also the mechanical power is below the threshold of 17. These are the figures. So again, the tidal volume for RDS patient, whatever the severity, is between 4 and 8, and the driving pressure is below 15. Now we have a second study on the same topic. It comes from Dr. Butman in Netherlands, where she include 24 passive patients. The patients were ventilated in pressure control with the setting made by the clinician. And then they switched the patient to the ventilation controller of IntelliVent ASV, and they studied the tidal volume, the driving pressure, and the mechanical power. In terms of tidal volume, so red is pressure control, blue is ASV, IntelliVent ASV. So in terms of tidal volume, there were no difference between the two modes. In terms of minute ventilation, also no difference. In terms of driving pressure, there was no difference, but in terms of respiratory rate, the respiratory rate in IntelliVent ASV was lower as compared as the conventional mode. And the consequence is that the mechanical power was lower also in IntelliVent ASV. So to conclude, individualized lung protective ventilation is a must. We should target to use it for every patient. And this is what most of the participants said at the beginning. It's a multi-parameter approach, meaning that it's quite complicated to use it on every patient at the bedside, and it requires a quite advanced knowledge and to use some special tools. ASV and IntelliVent ASV are, by design, can optimize some important variables, the tidal volume, the driving pressure, and the mechanical power. And the clinical results demonstrate a reduction in the intensity of mechanical ventilation. How does it impact the clinical outcome? For the moment, we don't have such studies, so it remains an open question. So I will close here. Thank you for your attention, and I will give back the talk to Marco.
Thank you very much, Jean-Michel, for this very elegant and clear talk, telling us the features of IntelliVent ASV and sharing with us some results of studies published on this book. We have already a few questions, up to 5 questions that have been addressed to you, Jean-Michel. I'm going to start with the first question. The first question says, I don't think that setting PEEP based on PEEP FiO2 table is the best way to individualize treatment. What's your opinion?
That's true. That's true. That's a very good question. Using a PEEP FiO2 table to set PEEP is one way to individualize, but it's based on oxygenation. It's not based on lung protection. I guess if you have to optimize, individualize a PEEP based on lung protection, we have to use transpulmonary pressure, but you can still use it in IntelliVent. You just have to turn off the PEEP controller and set it manually.
Can you give a range in the IntelliVent ASV mode? You would like to have the PEEP between 8 and 12, something like that. Is this possible?
Yes, yeah, you're right. In IntelliVent ASV, you have to set a range of PEEP if you want to use the automatic PEEP. And in my practice, I don't like to use very high or large range. I try to keep the range within 5 centimeters of water. So let's say, for example, between 5 and 10, or 10 and 15, or 8 and whatever.
Okay, thank you very much. So we have a second question from Eleonora, and she's asking, how does Intelivent deal with high patient drive?
Oh, that's a good
Respiratory
point.
drive.
Yeah, that's a very good point. So if the patient has a high drive, usually the patient is doing a large inspiratory effort. So the tidal volume is high, and the consequence will be that Intelivent ASV will decrease pressure support to the minimum, which is 5 centimeters of water. So there is a minimum pressure support. So you may say that by doing this, we try, Intelivent ASV, try to prevent too large tidal volume and too large transpulmonary pressure. However, the risk is that the patient exhausts. This is always a fear that if the patient has a very strong effort, at some point the patient exhausts. Well, in my practice, this is not the case. I'm amazed to see patients pulling for days and days and they don't exhaust. But anyway, if they do, then Intelivent, then the tidal volume will decrease at some point and pressure support will increase again. So for me, when we have patients with high drive, we should monitor them and assess their effort and see if we can keep them like this or if it's not safe. And in case we consider that it's not safe to keep large transpulmonary pressure or large tidal volume, then of course we have to play on the cause of the drive, which means usually to sedate a little bit the patient.
Okay, thank you for these answers. And we have now another question that is devoted to mechanical power. And the question is, how can we control mechanical power in Intelivent?
You cannot control it directly. So you measure mechanical power or you calculate mechanical power. But by design, again, Intelivent ASV try to reduce mechanical power by trying to use the lowest minute volume as possible, I would say, and accepting a little bit of permissive hypercapnia. Now, if you want a lower mechanical power, if you want to decrease more the mechanical power, then you have to target a higher CO2. By doing this, the ventilator will decrease the target minute volume and decrease more mechanical power.
Okay, perfect. Then we have another question that is addressed about spontaneous breathing. Most of the data show that Intelivent is used in passive patients. How it is about spontaneous breathing patient?
Well, again, for me, lung protection in SPONT patient is not so much about the ventilator setting, it's more about the patient effort. So we have to be very careful when patients have a high drive and very large patient effort. So I think that we have to monitor this, and now we have some tools. For example, the P01 is one way to monitor the drive, or we can measure the occlusion pressure, meaning that we do an end expiratory occlusion and look at the negative decrease of airway pressure to assess a little bit the patient effort. And in case the patient effort is too large, then we should not keep the patient like this, because there is a risk that this effort injures the lung by itself, whatever the mode and whatever the pressure support. And in this case, again, most of the time we have to sedate the patient.
The next question from Gennaro, it's a little bit going in the same direction, and is asking, how can Intelivent differentiate active patient when the mechanics are improving?
So Intelivent, is based on the respiratory mechanics, namely the expiratory time constant. So if the mechanics is improving, the target tidal volume will change. So let's say the patient was very restrictive with a short expiratory time constant, now becomes normal. So the target tidal volume will increase and the pressure support will adjust accordingly. This is how it works.
Okay. Then more practical questions that addresses CO2 and SpO2. How can you change targets for CO2 and SpO2? And how often do you do it?
So you can always change it. There are default targets, which are quite good in I believe in my practice. But of course, in some cases, they are not appropriate for a particular patient. So you may change a target. There is a setting called the target shift. And by doing this, you move the target. The CO2 target, we have to change it sometimes when there is a very large gap between end-tidal CO2 and PaCO2. So you may have to do this in severe RDS or severe COPD patients, but in most of the other cases, you can keep it by default. And for the SpO2, you can also shift the target, but honestly, it's very unusual that you have to do it. Most of the time, the default target are appropriate.
Okay, thank you very much. Now, also a practical question that addresses a little bit the potential limitation of IntelliVent ISV. Can we use IntelliVent ISV with large leakage?
Oh, that's a very good point. No, you are not supposed to use it when there is a large leak, because again, IntelliVent ISV is based on the expiratory time constant, which is measured at expiration. So if the expiratory tidal volume is not going through the flow sensor, then there is a risk that the expiratory time constant is wrong, and so we cannot use it. So that's a contraindication. Yeah.
Okay, I think there are a few other contraindications. Could you mention some of them?
Let's say if you have, you cannot use the oxygenation controller in case of dyshemoglobin, you know, this very rare patient where the SpO2 measurement is not correct. So it's, for example, sickle cell disease. So it's quite unusual in the ICU, but we still have to keep it in mind. And also if you have respiratory drive problems, such as a Shenstock breathing, it's not appropriate to use IntelliVent ISV. It's not dangerous, but the adjustment will be difficult, of course.
What about IntelliISV and ECMO? It's a question that comes to my mind just now. Is this a contraindication? Do you have experience?
I don't have experience, but I know that you have experience, Marco. So tell us about it, please.
Yes, I will do it maybe in May in another session. So
okay. Okay.
Stay with us and we'll know more about that in the future.
So it's possible, obviously it's possible.
I don't say more.
Okay.
Okay. Then we come a little bit to COVID, to the experience in COVID-19 patients. Do you have experience with IntelliVent in COVID-19 patients? How do you use it?
Yeah, well, in my ICU, we used only IntelliVent ISV in case of COVID, and we were quite satisfied about it for several reasons. One of them is that in COVID patient, the access to the patient is not that easy, and having a ventilator that adjusts automatically the settings made our life, let's say, easier. But apart from this, I will share my screen again because I have a few slides probably on this. So there are some data about it. Again, from the group, sorry, from Dr. Buiteman in Netherlands. She repeated the study in passive COVID patients. So again, they switch their COVID patient from pressure control to IntelliVent ASV and look at the results. So here it's the tidal volume. Yellow is pressure control and blue is ASV. So as you can see, in terms of tidal volume, the tidal volume in ASV was a little bit higher than in pressure control. Why? Because I assume that the compliance was not so bad in this patient. So IntelliVent ASV used a tidal volume between 6 and 7. But what is interesting is that in terms of driving pressure, the driving pressure was lower in IntelliVent ASV as compared to their PCV. In terms of respiratory rate, again, it was lower in IntelliVent ASV, and so the conclusion in terms of mechanical power, the mechanical power was lower in IntelliVent ASV as compared to pressure control. And then we have another study on COVID, which came from Zurich, your previous ICU, Marco, where they use also IntelliVent ASV in COVID patients. And in this study, they compared pressure control versus IntelliVent ASV in 40 passive COVID patients. This was during the first wave. These patients were not randomized. They just compare the patient that were managed in pressure control and the patient that were managed in IntelliVent ASV. And what is interesting is that they were able to record the data for the first 7 days of mechanical ventilation. So quite nice study. In red is IntelliVent ASV, in blue is the conventional mode, which was pressure control. And here is the tidal volume over 7 days. You see no difference between the two modalities. Here is the respiratory rate. Again, the respiratory rate was lower when they use IntelliVent ASV. Here is the driving pressure, the dynamic driving pressure, meaning peak pressure minus PEEP, where it shows also a lower driving pressure, and the dynamic mechanical power that was also lower. So again, it seems that with IntelliVent ASV, we have less intensity. And then they calculate a sort of overall full lung protective score, and they calculate the time spent with full lung protection, and they calculate that in their conventional mode, the patient spent 37% of the time with full protective ventilation, and it was almost double when they use IntelliVent ASV. And the difference, the most difference was on peak pressure, driving pressure, and mechanical power. So a long answer to say, yes, you can use it and you find the same benefit in COVID patient as in non-COVID.
We leave now COVID and we go for another important question. I think it's how does IntelliVent deal with patients with low chest compliance or high intra-abdominal pressure?
So patients with low chest compliance will have a decrease in the overall compliance. So IntelliVent will select a low tidal volume for this patient to keep driving pressure safe. And regarding oxygenation, if this patient have some atelectasis, of course, IntelliVent will increase FiO2 and PEEP to prevent atelectasis.
Okay. And now a question, maybe it's important because we're discussing about the P01 just before, and the question addresses IntelliVent, does it take the reading of effort into account?
No, it does not take this in the loop, not for the moment. And the reason is that for the moment, an automatic calculation of P01 is not robust enough to be used. So what we recommend is to do it yourself and to take decision according to it, but it's not automatically.
Maybe a last question now that is addresses a little bit on the limitation, something or people could be concerned about that in your ICU. what is your experience? When do you change from IntelliVent to a conventional mode?
Apart from what we discussed as contraindication, mainly the main leak, the large leak, it's very unusual. I would say that, you know, IntelliVent is a tool, is a mode. So when you are experienced, you can use it in almost all patients. But I would say that for the beginners, when you are not comfortable in a severe patient with IntelliVent, I think you should not keep it, and it's better that you use what you know, but you will see that with experience, you can use it in most of the patients, including sometimes the severe RDS or the severe COPD.
So thank you very much, Jean-Michel, for
Thank
your
you.
nice talk and all the answer that you gave to us and practical tips and tricks how to manage patient with IntelliVent SE. And so we are at the end of this session. I hand over to Caroline.
Thank you very much, Marco. So that's all we've got time for today, everybody. We have gone a bit over time, but thank you very much for staying with us. And of course, a big thank you to Jean-Michel and to Marco for their time today. So watch your inbox next week for the link to the recording, and also the link to the answers for any questions that we didn't address today. Don't forget, they are on our website, so follow that link if your question hasn't been answered today. And we'll also send you links to the upcoming webinars in this series that are scheduled for February 21st and March 16th. If you're already signed up, you don't need to register again for the upcoming events. You'll automatically receive the links. If you're not already signed up, you can do so very soon using the QR code that will be shown here. And when you leave this session, please just take a moment to answer the few short questions that will appear on your screen. So thank you very much, everybody. Bye for now. Thanks for your feedback. Thanks for joining us. And we look forward to seeing you again on February 21st. Bye-bye.